Hi. So today I really want to speak about hemolytic anemia. All right, and there's not much to write. It's more about speaking. So first, I really want to understand, and I really want people to understand this very important aspect that is usually tested, is that anemia, hemolytic anemia in specific. First, three things that you want to look at when you're talking about hemolytic anemia is, first of all, you want to look for your RBC count, which is obviously going to be low. Your hemoglobin is obviously going to be low, because of which it is anemia. Something that you have to look at is your reti count. Your reti count is so important because your reti count is going to be high. Why? Because there is the bone marrow. The bone marrow is seemingly all right. Rather, it's compensating for all the loss of RBCs that we are having, right? So yes, so that is something that I want people to understand up straight right now. Then certain things that we can also say is that you could have your serum iron levels that could be low. Your ferritin could be low, right? Ferritin also could be low. Why? Because of these consumption of iron with increased production of RBCs. You also want to understand is that your RBCs, they could have your reticulocytes, all right, would be released into the blood quicker, okay, into the bloodstream, because of which when you actually look at the peripheral blood smear, not only would you see hemolysis if it is intravascular, obviously. Okay, so hemolysis could be intravascular or extravascular. If it's intravascular, you could very well see it. But if it's extravascular, you can't see it. But what you'd definitely be able to see is would be reticulocyte or larger RBCs. Okay, now that would actually push you towards something. All right, so these are something that straight up should actually get into your head. Something else that should actually get into our understanding is the importance of haptoglobin. The importance of, let me just get rid of this, the importance of haptoglobin is this molecule that actually binds to that. I hope you've got it right. So it actually binds, and when there's erythrocytic destruction, your haptoglobin levels should drop because it binds to what? As I said, hemoglobin. Yes, similarly, there's another molecule that is less commonly spoken of. It's called hemopexin, very similar to haptoglobin, and that would also be reduced. Now, straight up, we've sorted a few lab features that we can see when it comes to hemolytic anemia. Now it'll be easier for us to understand the different causes of hemolytic anemia. So let's begin directly without wasting much time. So hemolytic anemia could be intravascular or extravascular. If it's intravascular, you're probably thinking about stuff that is actually causing lysis, right, inside the vessel. If you're talking about extravascular, you're probably thinking about the spleen and the liver, but morely and more commonly, predominantly the spleen. All right. So when I'm saying intravascular, it could probably be any heart valve. All right. It could be DICs. It could be, you know what? It could be TTPs. It could be probably malaria, Kala Azar. But again, that could also be extravascular for malaria as well. It could be. It could probably be a G6PD. Actually, more not a G6PD. G6PD would more go into splenic. Actually, it would be pretty much mixed. G6PD could be here as well as here. So let's not get into G6PD for now. It could very well be intravascular cold hemolysis, probably agglutination, right? So it could be any of these. If it's extravascular, you probably want to first of all think about stuff like sickle, thal, but again, those are not hemolysis. So you could talk about sickle, you could talk about autoimmune hemolytic anemia, obviously of the warm type. You could probably even talk about G6PD here, You could probably even talk about hemolytic reactions, transfusion reactions, and so on and so forth. Porphyrias, lipid defects, lipid membrane defects, hereditary spherocytosis, any of those sorts. But again, we would not get into HS as much as we would get into the other stuff. So classifying them as intra and extravascular is important, but knowing the cause and understanding and getting into the basics of it and getting a strong understanding is imperative, right? So we've spoken about the lab findings, which is very important for us to diagnose this, right? Another very important lab finding, because now we've classified as extravascular and intravascular, it's very important lab finding in extravascular would be your bilirubin levels. So you really want to look at your bilirubin levels, and then you want to check for anemia. If both of these things are given in your case, and both of them are, your anemia is positive, all right, because your hemoglobin is low and your bilirubin levels are high. Now you want to check what bilirubin. Obviously, they'll tell you that the unconjugated bilirubin is increased, right? Your unconjugated bilirubin is increased. Second is that if they are talking about intravascular, they will definitely give you a thing called as haptoglobin. They have to. They will give you an haptoglobin low, or probably they will say there's a schistocyte, or they will show you some blur cells, right? Blur cells, or something very specific, pointing towards intravascular hemolysis, right? So these are your identifying points, right? These are your identifying points that you want. Second, they might just go on to your bone marrow, and when they talk about your bone marrow, they might just say there is hyperplasia of the bone marrow. Do not get into stuff like AML, CML, unless you have sufficient evidence to get into those DDs, right? If your evidence is just about anemia, bilirubin levels probably high, haptoglobin, and something which is very specific to intravascular hemolysis, then you want to get into something as basic and as simple as anemia, hemolytic anemia. Now, how would you want to differentiate between the different causes of hemolytic anemias, right? So there are a few things that you should keep in mind. First, if they are talking about spectrin, if they're talking about ankyrin, they are probably hinting towards HS. If they're talking about HS, they are probably telling you about, how the MCVs and MCH is going to be. So MCV is that you'll have decreased MCV, mean corpuscular volume, because now they are circular, and MCH is increased because of hemoconcentration. Hemoglobin is concentrated. Second is that they would obviously give you an osmotic fragility test, right? They would give you an osmotic fragility test. Now that's something that they will definitely hint you towards, right? Also, they will tell you that it's an extravascular hemolysis, straight up, right? With gallstones, pigmented mixed gallstones, all right? Okay, so that is something that you definitely want to look and get into straight up when someone is hinting towards HS, all right? Second is if they are talking about something like a G6PD. First, they might just talk about your Heinz body, all right? They might talk about drugs like Primaquine. Okay, they might talk about the EMP shunt, just to get a little bit of biochemistry in the middle, right? And they might talk about band 3 plus Heinz body complex, right? And then they might talk about the bite cells. Okay, so basically the RBC with the Heinz body gets attached to the band 3 complex, and the band 3 complex is then phagocytosed by the splenic macrophages, right? So they actually form something called as a bite, as if you've taken a bite, and it forms a bite cell. They'll tell you this, all right? Simple stuff. So far so good. All right, and then they will also talk about yes, they will definitely tell you drugs like sulfamethoxazole, sulfa drugs, any sulfa drugs. As I said, primaquine, quinine. They will talk about nitrofurantoin, dapsone, methylene blue, nalidixic acid, which is an NSAID. All right, some NSAIDs as well, but nitrofurantoin very important. Nitrofurantoin is an they would say that you've been given nitrofurantoin for probably a UTI, right, and get you there, or you've been giving dapsone for like leprosy, or where else would you give it? Usually for leprosy, or you've given methylene blue for maybe cyanide toxicity. So all of those could be. Then you might just be getting into autoimmune hemolytic anemia. Finally, so important. So you should talk about warm and cold. If they're talking about warm, they are usually hinting you towards IgG. If they're talking about cold, they're talking about IgM. All right. They will definitely give you a history of SLE, Hep B, UTIs. Let me make it URTIs actually, your upper respiratory tract infection, and yes, so they would obviously give you stuff like all of this Hep B and all, and they would want you to figure out if it's your warm variant or your cold variant. All right, how would you do that? Well, they would actually tell you. They would tell you that when and at what temperature does it occur. So if it's like at 37 degrees Celsius, you're probably talking about warm. 4 degrees Celsius, you're talking about cold. Now, both act in their respective ways by forming IgG actually gets bound to the RBCs. IgG, it binds to the RBCs and then to the spleen they go. But what happens with IgM is that they could actually stimulate the complement cascade, right? They stimulate the complement cascade. We know about it, right? We know about it. Right, so because of complement activation, hemolysis occurs, maybe intravascular as well. And something with cold is that autoimmune hemolytic anemia is that you have to remember that it is associated with EBV, mycoplasma, CMV, and also sometimes penicillin. Very important. Very important, right? So that is something that they are kind of hinting you towards. Right? They want you to figure out that, okay, this could be another cause. And how do you treat any of these is that you give IVIG so that these immunoglobulins bind to these IVIG and just get excreted out. Also, you could start as corticosteroids, obviously, without a doubt. Sometimes you might have to go for something called as a rituximab. Now, why? Because rituximab is a CD20 monoclonal antibody, right? So they bind to CD20 and kind of inactivate them. Now, CD20 is something that you see on B cells, more likely on mature B cells. Now, when you see it on these mature B cells, right, CD20 specifically, you know that B cells are going to produce antibodies, right? And now if the CD20 is blocking them, you cannot produce antibodies. Screw any kind of an antibody. You can't even produce an autoimmune antibody. And that is in its way very helpful. Right? So yes, correct. So this is literally what it is when it comes to autoimmune hemolytic anemia. I mean, these are the very high yield points. I do not think they would ever want to get into something else. All right. So that is about it. Thank you very much.